Good afternoon, everyone. Welcome to the Independent Sage Friday briefing. The importance of data and modelling, especially during a pandemic like COVID-19, can't be overstated. Having access to the right data and being able to chart important trends and modelling has not only allowed us to track variants and levels of infection, but also make assessments about risk and decide on the precautions needed. SAGE modelers use the very latest data to project possible paths of the pandemic forward in time to support policy. But a lot of data collection has now stopped, and SPIM no longer meet. What did it all mean? How did it support decisions? To discuss this and more on data and modelling, we have with us a very, very special guest today, Bob Hawkins. Now, Bob worked for over 30 years in the European arm of a major global car company. He started work in the operational research department developing simulation models to help improve the layout of new production lines and finished his career as the IT strategy manager. In between, he worked in the sales planning, manufacturing, and IT departments, where a common thread was to use data and modelling to improve decision-making and processes. He's also worked on research projects with several universities, particularly in the area of modelling the order fulfillment process. He is now retired and spends his time supporting local food banks, acting as the treasurer for the local Scouts group, as well as preparing some of the data for all the charts we present at Indie Sage. Welcome, Bob. Thank you so much for joining us today. We're really excited to meet you, and thank you for your continued efforts in helping us to present data and trends for our briefings. We're so grateful. But before we get to the main session, I'm going to give you a situation update, especially with regard to some of the long COVID research we are seeing. So I think you should be able to see some slides now. I'm not going to discuss a piece on long COVID that had some airtime recently, as it was rather a selected piece that had some inherent bias in the study design. Instead, I'm going to mention two research papers that have been very significant. So a lot of studies have looked at the prevalence of long COVID, and the rates of prevalence really vary from 5 to 35%. This latest study looked at thousands of people before they were infected and tracked them over time, and they used age and sex matched controls. In that cohort, around 1 in 8 people who got COVID developed long COVID. Now, this study was performed before the Omicron era, but data has shown in the UK that around 700,000 cases have occurred since Omicron. In the second study, computational approaches were combined with some very, very deep focused immunology. They revealed 3 symptom clusters and patient-reported outcomes that could identify long COVID with 94% accuracy. People with long COVID had much lower circulating levels of a stress hormone called cortisol. And they also had features consistent with a sort of heightened immune activation. So they had heightened activation of T cells and B cells, the ones that make antibody. They had lots of spike antibodies. And there seemed to be evidence of reactivation of latent viruses like EBV. So this could be a really useful study in helping predict who's going to get it, but also helping manage treatment. Another new study showed that is sort of started to put together the story of why COVID is associated with a higher risk of cardiovascular disease. So it showed that not only did the virus infect blood vessels, but it changed the programming of white blood cells called macrophages. So they were much more likely to take up lipids or fats, and there were also changes in the way that lipids and fats were metabolized. And all of this is more consistent with the enhanced likelihood of developing plaques and cardiovascular disease. So moving away from the immunology, there's been a really exciting piece of work that involves citizen scientists working in partnership with scientists to track viral genomes. And they showed how an antiviral drug can help shape the SARS-CoV-2 genome. Now, this didn't mean that the virus became more infectious or immune evasive, but nonetheless, it highlights the importance of looking at how we use antivirals and the valuable role that everyone can play in COVID research. And some exciting developments in vaccines happened in the UK because we're now rolling out the XBB1 mRNA boosters, and they may perform a little bit better against the so-called Parola variant. And the USA has approved a type of vaccine called Novavax, which is a protein vaccine. And this may prove to be a slightly more durable vaccine, giving us a broader protection against COVID variants. And you may be aware that the module 2 of the COVID inquiry has started this week. It's focusing on decision-making by the government and has been revealing already some disparities between science advice and governmental action. Inconsistencies from Boris Johnson as to the approach, a rather unpleasant view he held about long COVID, and a lack of scientific input into our now Prime Minister's Eat Out to Help Out scheme. And Stuart McDonald, a founder or co-chair of the COVID-19 Actuary Group, was on this week's More or Less on Radio 4, and he was debunking the claim that somebody called John Campbell had shared in one of his YouTube videos. And this has around 2.9 million followers. And he was claiming that 100,000 excess deaths were due to vaccination compared to no one being vaccinated. So Stuart McDonald was able to robustly debunk this as fraudulent spliced data. And I'm pleased to say that the video has now been taken off YouTube. And I will stop there with the situation update this week, and I will now pass it to our maestro with the numbers, Professor Christina Pagel, who is presenting the very latest numbers and setting the stage for today's main session on data and modelling. Over to you, Christina.
Okay, thank you. Let me share my screen. So I'm going to cover the latest numbers using as much data as we've got at the moment. And then I'm actually going to kind of take us on a tour of the last 3 years of what data there was and no longer is, before kind of opening it to a discussion with me, Duncan, Kit, and Bob about data. And Kit's going to also talk about the modelling that happened and how that supported. So that's kind of what to expect for the next half hour or so. So in terms of numbers, I'm going to go through vaccines, cases, hospitalizations and death variants, and then just something I wanted to highlight about sickness and the workforce. So on vaccines, the autumn booster campaign has now started. This is data from NHS England. You can see it started here and is going quite quickly, about the same as it did a year ago. So far, they've delivered 3 million doses, and in the most recent week, 1.5 million. Now, NHS England haven't yet released uptake estimates. That's coming next week from UKHSA, but they say they reckon there are about 21.5 million people eligible for the booster. And so given that, we're actually still at quite low uptake, about 14% of people have had it in England. Scotland has also started its autumn rollout, seems to be going well. We don't know what the uptake is yet. We don't have an estimate of the denominator population, but Wales has published quite detailed estimates of its autumn booster programme. So you can see they've done pretty well in getting it to care home residents who are most vulnerable. 2/3 of those have had their autumn booster, but the other groups are still very much at the beginning. So these numbers will be updated over the coming months. There was recent polling that came out, though, that showed that only 1/3 of people are aware about who can actually get the autumn COVID booster. So this, I think, is a sign of failure of communication. And it means that many people will not know that they're eligible and not turn up. And some people will think they are and not turn up, and they'll turn up and not be able to get it, which also creates problems. So I just want to highlight exactly who is eligible this autumn. It's the over 65s anyone between 6 months to 64 years old who is at increased risk, and this includes pregnancy. So I just want to highlight that includes, if you're pregnant, you are eligible for a booster, and I would urge you to take it. It's really protective for you and for your baby. People living in a care home, if you're a frontline health worker, but also if you're age 16 to 64 and are a carer, or you live with someone with a weakened immune system. So if you're in regular contact with someone who is vulnerable, you might well be eligible. So please also consider that route. So cases, I haven't said much about cases for a while because we haven't really had any information on it. That's still the case, but I just want to kind of say what is there. So we do have Google Trends data on searches. Now that's not good data, but it's also some information, right? We don't have ONS anymore. The Zoe symptom tracker is kind of stopped, and we don't have wastewater data in England. But this is what the Google search looks like for symptoms of COVID over the past year. And you can see now it's at the highest level it's been for a year. Now, again, we can't say that definitely means there's loads of COVID, but it certainly is consistent with there being quite a lot of COVID around. If you do have symptoms of a cold or flu, then you probably have either COVID or a rhinovirus cold. So UK HSA surveillance data to 24th of September shows that there's very little, this is flu and RSV, there's very little flu and RSV around. There is quite a lot of COVID around. This is likely to go up again, as we'll see later. But they also, in the separate plot, show there's also quite a lot of rhinovirus, which is a virus that causes cold symptoms. And so basically, if you have that, it's going to be either rhinovirus or COVID. Please do test. It seems that people are kind of testing positive a little bit later on in their disease course than they used to. So if you test negative once, don't assume that that means you definitely don't have it. It's worth doing a couple of tests over a few days. There is some good news here, though. So the UK HSA and ONS are launching a new winter COVID-19 infection survey. So from November to March, we are going to start getting population estimates for how much COVID there is around, which is really good. However, they're only using lateral flow tests. So it does mean that we're not going to get the accuracy of the PCR, but we're also not going to get any new variant information. So that is a bit of a shame, but this is a lot better than nothing. So let's look at hospitals and deaths. And before I go into the hospital data, I just want to show you data on the number of PCR tests we've been doing every week in England. And you can see that it has kind of dropped off a cliff. So it first dropped off a cliff back in January 2022, and that's when we stopped doing confirmatory PCR testing for lateral flow tests in the community. So then PCRs were really only done mainly in hospital settings. And then there have been various kind of changes to what constitutes a test or what would prompt a test in hospital. We used to test everybody in hospital, and gradually over the last year, who gets tested has reduced and reduced. And you can see every time it has led to a kind of reduction in PCR. So if I just zoom in to the last bit, you can see that even the last change in April has led to fewer tests happening. So what this means is that when we look at admissions with a positive COVID test, they're not directly comparable over time. So just bear that in mind. So this is the number of daily admissions with COVID from May 2021 to September 2023. So you can see this is where we are now. And I'm just going to overlay on it the different testing eras. So admissions within each colour are comparable to each other, but not necessarily comparable to other colours. So this is where we are now. We're certainly as high as we have been in the last 6 months. It's going up. There's no particular sign that it's going to stop. And given the reduction in testing, we're probably not that far off where we were in this kind of era, but you can't really say. If we look regionally, admissions have gone up in every single region except London. So this is going on across the country except London, which is quite interesting, and I'm not quite sure why that would be. Critical care should be less affected by reduced testing. This is people test with COVID in critical care, because the standard is that everybody in critical care should get a test, and that hasn't changed. So in theory, this should be more comparable over time. And you can see here that that has also gone up there, but genuinely people are still getting quite sick with COVID. If we just look at this over a longer time period, going back to 2021, you can see how much this has changed. And really what we can see, this is Delta. And then we kind of went into Omicron, and we know that Omicron is certainly not mild, but it does seem to affect the lungs a bit less than Delta, which is one of the reasons people are in intensive care. But we also did a really, really big booster campaign exactly at this time, which will have had an impact. And also by this stage, you'll have also had some protection from people being previously infected. And so we have seen fewer people in critical care, which is a good thing, but it's certainly not the case that no one gets very sick from COVID. That is still happening. This is just yet another way of showing that there are still people in hospital with COVID. This is people who the hospital reports are saying definitely in hospital because of COVID, and that number has gone up. I just want to show what's happening in Scotland. So Scotland's the only UK nation that does wastewater collection. Unfortunately, they haven't updated it this week. So its data only goes up to September the 12th. And this is a big spike in September that they had there, late August, September, which was kind of on a par to the wave they had in July 2022, which was the BA5 wave, which was the last really big wave we had in England as well. And if we just overlay this on hospital admissions, which are the blue, you can see that there is a correspondence between seeing a wastewater spike and then a hospital spike a couple of weeks later. The size of the wave aren't that well correlated, but there definitely is one. And you can see the same things happened here. Now, the most recent hospital admission in Scotland shows an increase. So I suspect wastewater has gone up again in Scotland. So when and if they update it, we'll probably see that. But it does show that wastewater is a useful way of kind of tracking community prevalence. Just looking at deaths, because we've seen an increase in cases, we've seen an increase in hospital admissions, it's not surprising that we have also, unfortunately, seen a sustained increase in the number of people dying from COVID every week. This is England, but you see exactly the same pattern in Scotland and Northern Ireland, sorry, England and Wales, and you see the same thing in Scotland, Northern Ireland. Right, just a very quick variant update. UKHSA publish variant updates every couple of weeks. The last one was the end of September. And all I want you to get from this plot is that there are a lot of variants, right? We really do have a variant. See, most of them are what are called Omicron XBB lineages. But this little thing here, this maroon one, is BA 2.86, which is Parola, and that is growing. So various people are tracking it. There's a guy called Mike Honey, and he did this lovely simplified plot looking at the main variants. So we have the two dominant ones in England, what's called EG5 here, which you can see grew quite rapidly in August, and XBB 1.16, that was the old Arcturus, which is kind of grew and then kind of stuck around. And this is the new one, BA 2.86 or Parola. And although it looks like it's low, it is growing. So this is kind of the thing about exponential spread. Like you don't see, it doesn't look big to begin with. But if you compare the two, which is what Mike Honey did, he compared the growth of this, the new variant, to the current dominant one, EG5, and says, okay, well, is it growing quicker? And if so, what will happen? And what he shows is that it's growing, it has a growth advantage of about 14% every day. And if you just project that forward, it looks like this new variant could become the kind of the predominant variant in England by really the end of October, at least, probably a bit earlier. And so I think given that, we shouldn't expect this wave to suddenly stop over too soon, which is unfortunate. And then finally, just something on sickness. So we may be seeing slightly few people in hospital and few people in critical care, but there's no doubt that COVID waves could still cause a lot of reduction. We've had headlines this month of sick days at work being the highest level for 10 years. We saw many flights cancelled because of the COVID wave in air traffic control. And we've had more reports of schools being quite disrupted through COVID, going through classes and through teachers. So it certainly hasn't gone away and it hasn't stopped affecting us. And we've also seen continuingly bad news about the number of people out of work through long-term sickness. It's at record levels, 2.6 billion. as of July 2023. Now, not all of it is due to COVID, but a lot of it is. So a lot of it will be people who are really affected by long COVID and haven't been able to work. Finally, I just want to talk about an opinion poll that was highlighted to me by Steve Reicher, that the public still care about COVID, that there may be this narrative that COVID's gone away and no one cares about it, but that just isn't true. This is a survey from Ipsos that came out this week. And really, they kind of asked people, what are you doing about COVID and what are you planning on doing in the next 2 weeks to try and stop getting COVID? So the dark blue is people saying, I plan to do this. And still a lot of people, surprising number of people, I think, are planning on doing things. So things like taking lateral flow tests, wearing a face mask, working from home instead of going into the office. So voluntarily restricting what they do to try and avoid catching COVID. And what's also surprising is that young people, so say adults 16 to 24, are more likely to say they're going to do these things than older adults. So it's not the case that it's kind of the young don't care. Like, that's just not true. And I also thought this was quite interesting. Okay, most people are still going out and socializing, but actually, you know, a third of people are saying that they're going to reduce going to pubs and restaurants and avoid public transport. And it just brings us back to what India Sage have been saying, you know, all along, like a really concerted effort to improve indoor air quality will not only reduce transmission and have other public health benefits, but it's also going to be good for the economy, because there are a lot of people out there who would go out if they felt it was safer to do so. And just the last bit I wanted to highlight from this poll is they also asked people what would happen if they tested positive. So this is the percentage of people saying they'd be unlikely to do these activities if they tested positive for COVID. So you want these to be quite high, really, things like visit elderly relatives or go to work with COVID. And they are quite high. So actually, most people would not visit elderly relatives if they had COVID. They'd avoid public transport, they'd avoid work. So people do still care about infecting other people. It's quite interesting that actually a lot of people say they will go for a walk outside. And I think that's because people do understand transmission, and the message that outside is safer does seem to have got through. Right, so to summarize the numbers. Autumn boosters are underway for the over 65s and immunocompromised. Do get one if you're eligible. We are in the middle of a significant infection wave. I don't know how big it is because we don't have that data, but I think there's no doubt that we are in one. And I think it might well continue for a while as these new variants grow. Unfortunately, that means hospitalizations and death have gone up, and they probably will continue to go up. But the boosters will help blunt the impact on hospitalizations and death, especially as more people get boosted, but less so on transmission because younger adults and children are not eligible. We are seeing signs of acute disruption in workplaces and schools. We do know that this infection wave will cause more long COVID, but we're not measuring it anymore. So we don't know what the scale of that impact is going to be. And finally, just to say that the ONS infection survey in reduced form returns in November. So we should have better data from middle of November onwards. So that's kind of the numbers. That's where we are now. That's the kind of data that we have available. And I think you can see that we can say less about what's happening than we used to be able to say. So I wanted to kind of take you on a tour of retrospectively, you know, what did we used to have? What are the kind of things we used to be able to talk about? And then have a little bit of reflection of what that meant. Like, you know, was it useful to know these things? So let's start with thinking about prevalence. We actually used to have a lot of information about how much COVID there is around at the moment, right? We had the ONS infection survey, so we could compare prevalence over time and between country. This is from April 2022, and you could see, you know, just quite how much COVID there was around. Like, we just don't have that kind of information now. I could not tell you where we are now, probably somewhere around here, but that's a pure guess. We used to be able to break that down into regional information. We used to be able to break it down by age. And we also being able to combine those two things, and because it was every week, we could do really nice things like make these plots. This is from Paul Mainwood, where you could see the impact of spreading in school. So this is the first kind of half term of the year, and you could see you have big increase in school-age kids, and then it would ripple through to parents and grandparents over time. And I thought that, you know, you could do those really lovely things with that kind of prevalence data. We also had the REACT study. This was run by Imperial, where they tested 100,000 people, randomly chosen to be representative every month. This went on for almost 2 years, and it was an incredible data set. It ended, its funding was dropped in March 2022. I'm still quite sad about it. This was the last ever report. Stopped at 6% prevalence. That was the BA2 wave in March 2022. The nice thing about REACT was that it had amazing demographic data. So it had age and region, but it also had things like key worker status, ethnicity, household size, deprivation index. And really the REACT study taught us so much about how COVID was transmitting and where it was transmitting. The Zoe Symptom Tracker app was quite a useful thing because it was most up to date. It was updated every day and was dependent on people inputting their symptoms. Now it's become increasingly unreliable because fewer people are using it. And it hasn't been updated since the 8th of September. And I suspect it probably won't come back if people aren't using it, because it just doesn't really tell you very much anymore. But that was very useful for spotting early trends. We also did have wastewater data in England and Wales. It was incredibly granular. Like this is an example from Yorkshire and the Humber in 2021. And we stopped, right? It stopped in March 2022. No real reason was given. But I still think this was a real missed opportunity for us to know about COVID prevalence. So that was prevalence. And one of the things that I basically stopped showing completely for the last year and a half is cases, right? We used to talk a lot about ascertained new cases, how many people tested positive. And essentially that data has kind of gone away as people have stopped testing. You know, tests stopped being free, there stopped being a requirement to test or isolate. And so really it doesn't tell you that much anymore, but it used to tell us a lot and was really up to date, updated every single day. So we used to see these kind of plots all the time. This is from January 2021 of people with a new confirmed case. We used to be able to look at positivity rate, which was a really useful way of trying to understand increases in COVID that were less susceptible to changes in how many people got tested. Because obviously the more you test, the more cases you see, but you want to know, is that a real increase or not? So that's what positivity can give you. And so we could look at things like the impact of, this was the Welsh fire break in October 2020. We had amazing granularity. We could go right down to local authority and borough level. And Bob used to do these beautiful plots where we could kind of see here in December 2021 increases everywhere in London, say, and where they were concentrated in London. We could make lovely maps that kind of showed concentration. Here you could see there was a massive hotspot in the northwest. We could look at the impact of tiers in 2020. This is December 2020, not December 2021 there. We could look at the impact of what the regional restrictions were doing, how were things going in different tiers. We could look at things by age and deprivation. So really try and understand, like, where is COVID happening, in which bits of the population, who's most vulnerable. Here we can see data from UKHSA showing that cases were really concentrated in the most deprived areas. We could look at hotspots. This was a hotspot in Kettering in October 2021, really showing here clearly a school outbreak where you can see incredibly high cases in younger children, then older children, and then adults right at the bottom. So you can kind of see how we could really dig in and try and understand what was happening. It allowed us to do things like spot the Immensa scandal, where thousands of people were told they didn't have COVID when they did in the southwest, and you could see the corresponding massive increase in transmission. So I think now, if there was some kind of massive testing issue, I don't think we would spot it. I mean, hardly anyone's getting tested, but even if they were, I just don't think we could see it. Long COVID is something that we actually had some of the best data in the world on. This is from ONS Infection Survey. We knew how many people had it. We knew the impact on their lives. We knew how old they were, what professions they were in, and how it's split by deprivation. That's all incredibly important information about long COVID. And effectively, we're now stuck at March 2023 when it stopped. And I don't know how we'll recover that information going forward. React also did some really good long COVID work. They looked at how long systems persisted. They did some really good work trying to identify what are the main symptoms of long COVID that people are experiencing, and also what the risk factors are. And they kind of identified that, age, sex, weight, and income were really important kind of risk factors. Inequalities is something we talked about a lot in IndySage. We used to have a lot of data on it. Just one thing I want to highlight is there was this Public Health England tool called CHIME, which is specifically designed to help decision makers and the public explore the impact of COVID on through a health inequalities perspective. They haven't updated it since March 2023. I suspect it's been mothballed. And that meant that we can't do things anymore like look at hospital admission rates by deprivation, or death rates by deprivation of ethnicity, or any other kind of demographic that we would like to look at. SAGE reports were incredibly important bits of information. We talked about them a lot on Independent SAGE. They obviously went to government to help inform policy, but they did so much, right? There were the consensus notes on exactly what was happening with COVID at that time. Was it growing? Was it shrinking? What's the doubling time? And so on. They had reports on how many people were actually adhering to, say, contact tracing. They did reports on what would happen, or, what would happen if you supported people financially to isolate. By the way, the recommendations of SPI-B were never implemented by the government on the need to support isolation. They gave a kind of quite big picture in their monthly minutes of exactly what was happening, the impact of different measures and what measures could be used in the future. They looked at transmission routes. They looked at relaxation of measures or looking at opening schools. I mean, it was incredibly rich information that was out in the public domain with a delay, but it was out there and it was available. We had test and trace data. Obviously, test and trace is now finished, but that gave us a lot of information from really early on. This is from the summer of 2020. And you could see quite early on that we knew we weren't reaching enough people. The Royal Statistical Society here estimating only 30% of external contacts are being reached. We could see exactly where people were being contacted or not contacted. So we could see that in some deprived areas and in hotspots, contact tracing was actually less effective, which is exactly not how you want it to be. We could see the impact of testing crunches like we had in September 2020, when we could see that people weren't getting test results within 24 hours. We could see exactly who was a contact of other people, and work out where was transmission happening. So these are all really, really important information from test and trace. What we never knew from it was how many people actually isolated. That's not a measure that was reported. And we also didn't know how many people actually knew how to test and when to get tested. But we still could have used all of this information to improve test and trace from the summer of 2020 onwards, and we really didn't. It was quite interesting. we knew all these things, we knew where it was failing, and very little was done to improve it for a long time. We still have information on variants, but much less. And that's really because there are far, far fewer PCR tests being done now, as you saw earlier when I was showing you about hospitalizations. But so we used to be able to do things like from the COG UK and Wellcome Sanger data, we used to be able to look really good closely and spot really, really early spread of variants. So this is Delta, actually, back in the spring of 2021. And we could watch it growing from very, very low numbers. And now, because of the lack of PCR tests, we probably wouldn't spot it until we're out here somewhere, because we're just not doing the number of tests that you'd need to spot this kind of new thing happening. We could also look at it by region, and even local authority data that was available, where you could really kind of watch things spreading. You could see that with the Alpha variant back when that spread from Kent in 2020. Schools, we had a lot of information about schools, which has now stopped being collected. We could see exactly how many students were absent through COVID. We could see how many teachers were absent through COVID, and you can see it grow every term, and they're going to be disrupted by holidays and half term. We knew how many tests were being done, particularly once routine LFD testing was implemented in secondary schools. And we could see where there were outbreaks. This is from UKHSO back in 2020. So again, we had a lot of information there about how COVID was impacting schools. Interestingly, we weren't really using it. Right, I think I might need to speed up a bit, but I haven't got that much long left. I just want to highlight, the ONS did a lot of really important social surveys throughout. They showed us, what do people think about school closures? Were they worried about children going to school? How were restrictions impacting behaviours? How many people took tests? How many people did social distancing? How did it affect businesses? How did people adhere to self-isolation? All of these things are being collected by the ONS social surveys, which are really important in understanding what was happening with COVID. And perhaps most importantly, we also knew what was happening abroad, and we could really see, okay, especially in the summer of 2020, when we didn't know how we were going to come out of lockdown, we could see Spain having a surge after they reopened. We could see South Korea doing amazingly without a lockdown. We could see countries who had suppressed finding it difficult to maintain suppression and trying to understand why that is. We could see that many countries, especially here, Japan, South Korea, Vietnam, had surges and brought them down without a lockdown, right? So we could see that there were other ways of doing things than things that we were trying. So I think that was really important information that we had. We could understand what was happening in other European countries. You know, this is to see, you know, how does it affect what we do next? You could see the impact of really important events. This was before Christmas, so this is Thanksgiving in Canada and the US, and we could see how it then kind of created surges in both countries. And we could look at vaccination and how different vaccination policies happen. So here you can see England was one country that didn't really vaccinate the under 18s for very long, until quite a long time. So that's kind of all the data we had. So what does it mean? Like, what does it matter? You know what, I realise we're at 10 past and now I'm feeling really bad because it's taking far too long. So all I'm going to say here is there are a lot of biases, and people often misinterpreted data throughout, right? People forgot that asymptomatic people who could spread COVID are not in the stats, really, unless it was a random survey like ONS infection survey. To get in the stats, you have to get a test. A lot of people weren't getting tested, and that's always managed to skew who's in the cases. Now we only have hospital data, so we miss transmission in young people completely. So I think that is a big bias that a lot of people also have failed to understand. And the same with deaths. Like, deaths happen a lot later. They never tell you about what's happening right now. And also they're a very specific population. It tends to be skewed towards older and much more vulnerable people. And we never really measured long COVID. And because we never measured it, we never cared about it sufficiently when it came to policy. Different countries measure the same thing differently, right? We've changed how we measure things over time. Different countries' policies on infection and vaccination mean that we can't really compare different countries anymore. Variants mean that you can't just look at overall cases. You have to look at which variants are growing and waning. Reinfection data was never really well covered. And this is my last slide. So, you know, we had world-class data in the UK, and we had excellent synthesis of data, right? So we knew how to support policymaking, right? It was there, but the government didn't learn, right? It wasn't that we didn't know things, it was that knowledge wasn't acted upon. So that's kind of what I want to say about data. We had amazing data, but we didn't really use it effectively. And so with that, I just want to say sorry for going on too long. And then I do want to ask Bob a question. As somebody who's helped so much with all of this stuff, how did you find kind of the challenge of trying to find good data and good metrics to kind of make people understand?
So, Christina, thank you first of all for inviting me to join this great session, and your tour de force was quite amazing, well worth the time. Metrics need to be treated with care. That would be my main message. And I'd like to just use case positivity as an example of why it's important to understand how metrics are calculated to avoid misinterpreting them. And one little bugbear of mine, how setting metrics as performance targets for organization can have unforeseen consequences. And the example that I'd like to focus on is case positivity. Now, case positivity, what is it? Well, it's the number of positive tests on a day divided by the number of tests done, expressed as a percentage. It's important because it gives you a guide to how well your mass testing is doing at discovering the prevalence or the number of cases that are, the number of infections that are truly in the system. The higher the case positivity, then your testing regime is not picking up all infections. And in fact, the World Health Organization set a threshold of 5% for this measure. Below this threshold, you're doing a good job at picking up all infections. Above, not so good. In fact, you may remember that case positivity was one of the 5 metrics that the government defined to decide on the alert levels and to determine when we came out of the first lockdown back in 2020. As I said before, case positivity is the number of positive tests on a day divided by the number of tests. Sounds simple, but as always, the devil is in the detail. For example, you may think that the number of tests in a day, positive tests in a day, give an accurate measure of the number of new infections in a day. But that's not true. This is because the same individual can get tested many times. As an example, if you're tested positive on a Monday and then retest positive on a Friday, that would only count as 1 infection, but would show up as 2 cases. So to address this problem, we need to remove those duplicates to get a fair measure. From early in the pandemic, Scotland and Wales published daily case positivity on their dashboards. And the rule that they used was that any duplicate tests, whether positive or negative, within a rolling 7 days would be removed. Now, the first case positivity results for England were published some months later by Test and Trace. And rather than a daily metric, they published a weekly metric. And they chose to remove duplicate tests in a different way. So we then had, as Christina pointed out before, different measures across the different nations. The way that Test and Trace operated was that they removed any duplicate tests within a specific week, but any that crossed over that week remained. This meant that an individual testing positive on a Friday and then retesting positive on a Monday would be shown as 2 cases, whereas clearly it's just 1 case. It also meant that you would show a higher number of tests than following the Scottish and Welsh method. You may think that the public setting of the 100,000 tests per day target might Matt Hancock influence this choice, but I wouldn't possibly want to comment. Well, what are the consequences of making this choice? Well, not only did it lead to a double counting for some of the positive tests, it also gave a different view on the number of cases. And you could see this quite clearly when the Joint Biosecurity Centre was set up to be a single source of data for England, and they started publishing metrics in July, and they used the Scottish and Welsh method. The case positivity numbers were different from those reported by Test and Trace, and more significantly, the number of cases that Test and Trace were reporting were significantly higher than those that the Joint Biosecurity Centre were doing. Indeed, in October 2020, Test and Trace recorded 14% more cases than the Joint Biosecurity team. This gave me a nightmare in trying to understand what to provide as information to Christina around case positivity. Just looking at this one simple example, I hope you can see from this deep dive that you need to treat metrics with care, and it's best to understand how metrics are calculated. Big warning, always read the footnotes when you try and understand the data, and be careful when metrics are used as performance, because this will often impact on how they are calculated and reported. And with that, Christina, I'd like to hand back to you.
Thanks, Bob. And I think, we were so lucky that Bob did read all the footnotes, because he certainly saved us from making mistakes that way. So Kit, over to you to discuss the modelling side of things.
Oh, sorry, naive. I would have thought I'd be better at that by now. So obviously, data gives us a picture of what has happened and what's possibly currently happening. But to find out what is going to happen in the future, we need to do modelling. This isn't obviously the only purpose of modelling. We also use it for what's called nowcasting, finding out what the current situation is based on past data. And also we use it to suggest strategies like what interventions to take, what vaccine schedule should be used, and so on. So we're going to talk now a little bit more about modelling, its uses, its limitations, what happened during the pandemic, and maybe what could be done differently next time if we've got 7 or 8 minutes. So Duncan, I'm going to start by asking you, do you think we've learned lessons about modelling and about data?
Well, I think as can be seen by Christina's slides there, we've just come so far in terms of the last 3 years. And the amount of data has increased, but the amount of analysis has increased as well. And it's only by having good data and accurate data and timely data that you can actually go and do the analysis. So I think it's also interesting to see the sort of people who do this analysis. A lot of people on Twitter. And just a plug out to the sort of people that do this. Bob mentioned being an operational researcher. I think Christina and I would describe ourselves as being that. Kit in maths. So there's a lot of people contributing to the analysis. A lot of it has been kind of open source on Twitter, and analysis of people who don't do this as a day job and have done it. But it's only because that data is available, and the trust in data has been tremendous. So communicating that data has been as important as the data itself. And I think, you have to say that UKHSA have done a tremendous job in making that data available, both in terms of the dashboard that they did, but also in enabling people to download that data and analyse it. So it's been, an exemplary way of communicating that data. As Bob mentioned, data can be misinterpreted. And I think, read the footnotes, but just think about what the data actually means. And bad actors can misinterpret this data accidentally or on purpose. So having people who can communicate that data and are trusted is very important. There's a lot of complexity in the data, and just trying to make it as simple as possible. And I think looking at that sort of what's going to be in place for next time, if there is hopefully not a next time, that new dashboard. So I just think just another thing is that in terms of models, visualization of models is important. I think lots of things have been kind of behind the scenes, and I think making it visual is important, and that's difficult. But I think it's something that could be improved in the future. And I think communication is so important. I think one thing, though, I think if you look at the modelling groups that have been around in the UK, they've been UK groups, which you kind of think was the case. But I think, COVID has been such a global problem, and it was interesting to see how it became a kind of local problem, a national problem all around, for hundreds of countries. And I think just to finish, I think the modelling that has been done has been great, but there have been different groups doing that modelling. And I think, we've seen things called consensus statements, where it's not just one person saying, I think, but it's lots of different independent groups working together to get a consensus. And I think, that is something that's been good. And of course, getting that data and analysis into policy is a whole different question, but I'll pass back to you there.
So I think maybe our last question before we go to public questions is to Kit. You hear the phrase, all models are wrong, but some models are useful. And how do you think that that's kind of manifested itself over the pandemic, and what it kind of means for the next pandemic?
Yeah, I think the first thing to say is probably that modelers didn't always get things right. We know, like, for example, in July 2021, ahead of what was christened Freedom Day, Sajid Javid warned that there could be 100 or over 100,000 cases a day, and his figures were based on modelling from SPI-M, the modelling subgroup of SAGE, or that feeds into SAGE. And it seems that actually a lot of those rises that we'd seen leading up to that point, which fed into the models, were actually due to people mixing indoors more because of the men's Euros. And so in some senses they were artificial, and this was something that wasn't taken into account by the models. And the models do get things wrong. In particular, human behaviour is really difficult to account for in mathematical models. Models aren't so often predicated on assumptions that things will continue as they are now, which isn't always a good assumption. So when people hear about the spread of a deadly virus, they change their behaviour, and that influences what happens. And we've done some research on the impact of misinformation on people's behaviour. things get even more complicated when the outcome of the models themselves feeds back into what happened. So, for example, in March 2020, Imperial College's famous report 16, which predicted 250,000 people would die if we continued on our current trajectory, clearly influenced the government policy and led to the subsequent lockdown. But that didn't stop people like Carl Hennigan writing in The Spectator, calling, in his words, overstating the number of people who are going to die as his number one failure in the list of his 10 worst COVID data failures in the autumn of 2020, despite the fact that it was clear that that never came to pass because the government implemented the lockdown. And the fact that we've now seen over 230,000 COVID deaths, it isn't hard to imagine that we would see up to 250,000 potentially if we hadn't done anything. I think more generally, mathematical models are predicated on assumptions which are designed to simplify reality, how effective a vaccine is, how severe a variant is, what the impact of imposing or lifting a whole raft of mitigations will be. And these assumptions need to be updated as new evidence, for example, on the importance of airborne spread comes in. So in trying to quantify even these small number of unknowns, let alone the tens or hundreds of others, that we need to represent reality, we struggle as modelers. And that's why we run broad ranges of scenario, why we have strict caveats about the uncertainty around potential outcomes. And we try to accompany those with modeling reports. So I'll just finish by saying that every time someone interprets data, whether you're a professional mathematician or a politician or you're a member of the general public, you're using a model, whether you acknowledge it or not. And the difference is that good modelers are upfront about the assumptions that influence their outcomes. And if you don't agree with the underlying assumptions, then you should feel free to disagree or take issue with the projections. But dismissing conclusions of modeling simply because they're from a model doesn't make any sense. So I'll stop there and I'll hand back to Sheena for questions from the general public. Thanks.
Thank you so much, Kit, Christina, and Duncan, and of course, Bob. And that was great insights from Bob there. So now we're going to move to our Q&A session. And our first question is coming live to you, and it's coming from Noah. Can you join us, please, Noah?
Yeah, hi there. Can you hear and see me?
Yeah, we can hear you. Over to you.
All right. Excellent. Perfect. Thank you for having me. Really excellent presentation, and thank you for all the work you've been doing. I guess so. My question is, there are those of us who, like you, are still trying to do work around the ongoing pandemic, and I'm wondering, if we don't have institutional access or resources, what can we do? What kinds of data sets are there? Are we limited to Google Trends? Are we having to hope that the UKHSA, keeps things going? What is available to us to continue to try to make sense of what's happening out there?
Well, I think maybe the first thing to say is almost all the data that we've been showing has been publicly available. So I think that's been one great thing about the UK response is the data's been timely and available, and I think that's been an exemplar. And as Christina said, the level of data has gone down and down, but we're all still working on public data.
I mean, I would just add that not only is the data available, it's useful. Like, you can download it as an Excel file or a CSV file, whereas a lot of when I looked at some other countries, it was in a PDF, so it was not usable. So I think that has been really important. In terms of what we know now, it is much harder to infer what's going on. I don't know, Bob, if you want to say anything about that, since you're still trying to do it with us every couple of weeks.
I think it's very difficult to answer Noah's question. There is very little data that is available out there that can help at an individual level. So I think that the message is that you just need to be alert. People need to be aware that the virus is still there, and there is a risk associated with that. So it's not easy to answer your question, Noah, I'm afraid.
Thanks so much, everyone. And thank you so much, Noah, for joining us.
Thank you.
We've had lots and lots of questions in this week. I'm going to try and blend one of the questions because I think it sort of touches on a little bit of what we've just heard and a little bit, what Noah was asking, a little bit about what we've been talking about today. So there's these questions about Kim Moore and Sonia have sent questions, and they're asking about concerns about clinically vulnerable people and how they rely on published data. And they're sort of asking, what should they do to try and keep safe? And should they keep submitting data to the Zoe app? Because now they're getting this message saying it's stuck. So can the panel answer anything to do with that, please? I'm just looking for any hands. I can see Kit.
Yeah, it's a shame, Zoe. I've been trying to find out what's going on, and they basically don't have enough people reporting in order for their predictions to be sufficiently reliable. So I'd say yes, if you feel able to continue reporting, but I worry that it won't come back. I think the number of people reporting is only going to decrease, and that's going to reduce their reliability. Fortunately, we are going to have this COVID winter survey, which should give us a good picture of at least, maybe not relative to previous data. It may not be directly comparable because different measures of testing, but it should give us a good, from now on over the winter, a good idea of what's going on, whether cases are rising or falling. And I suppose always the precautionary principle comes into mind. It's do take those precautions, do test, do wear masks, do try and ventilate rooms, do try and meet outdoors, all those things that we've been saying throughout the pandemic. In the absence of a good set of data, then of course, be cautious in situations where you might be potentially catching COVID.
I can see Steve G has got his hand up. Over to you, Steve.
Yeah, well, I think it's safe to say that, as ever, clinically vulnerable people are at a loss as what to do, because as ever, the onus is on individuals to try and guesstimate their own risks. There's no public health interventions on a grand scale that help them live their lives normally. They're essentially abandoned, as they have been for years, and unable to really take any action other than the most precautionary that they possibly can. And that's really difficult in a society where everyone else is just carrying on. So I have huge sympathies, and I just wish that the UK would do things like Belgium and other countries have done to implement public health, better ventilation, clean air, etc., etc. It's not difficult. It really should be done, and it would have advantages in addition to COVID safety as well.
And Steve, the other Steve, I saw you had your hand up.
Yes. I just want to make a couple of comments relating to this from some of the data that Christina showed, the opinion poll data. I mean, the first thing is, one of the things that shows is actually the public is very sensible in trying to look at levels of risk and changing their behavior accordingly. So as the numbers of infections have gone up, so people have changed their behavior. So people want that information. They change their behavior on the basis of it. They need it. And so I think that's a really important point to make in arguing that the information is not only important for the scientists, not only important for us, it's a resource for people themselves, and it's a resource that people want. The second thing I want to stress is there's a lot of psychological evidence that when you look at why people adhered with COVID measures throughout the pandemic, it wasn't so much due to personal risk, it was due to risk to the community. Because a lot of people might have said, well, for me personally, it's not a great risk. I could go out with it being too dangerous. But once you start thinking of the community and the vulnerable in the community, you start thinking, well, if I go out, I might be killing people. And that stress on the community and that stress on the impact on vulnerable people was quite critical to the COVID responses. And I think one of the most tragic things is we've forgotten that entirely. All the stress on personal responsibility has made us selfish. And let's not forget, I mean, Andrew Cuomo is now disgraced, but at the beginning, he said, look, this pandemic is not an I thing, it's a we thing. Get your head around the we concept. We've forgotten about the we concept. And the final point I want to make is this. Again, as a psychologist, one of the things that comes over time and again is the thing that determines human behavior is not what we think, it's what we think others think. So very often, if we think that our views are out of kilter with everybody else, we don't act on them. Or if we believe that everybody else believes something, we'll do it. And I think one of the things that's going on at the moment is we're relentlessly told that nobody is taking COVID seriously, and people begin to think, well, I'm a bit weird, I'm a bit out of kilter if I wear a mask or if I argue for ventilation. And the fascinating thing is that when you do, you find lots of other people saying, yes, that's important, we want to act on it. So one of the things that data tells us is have the confidence to know that you are not alone, and that if you act, very often people will thank you for it because you're saying what they think, but they don't feel they can say.
Well said, Steve. I'm just going to take the last question now, and this was sent in from Colin Morgan, and he was asking how many people have died from COVID in the last 12 months in the UK, and how many are expected to die in the next 12 months. So it's quite a morbid question. Over to you. Who can answer that? Duncan, Christina, Kit? I'm looking at you.
I know that since January, it's been about 14,000 deaths from COVID, and 2022 was around 30,000 or 33,000, I think. So as to what we can expect from 2023, I mean, it depends a lot on what happens this autumn and how effective the boosters are, but we probably will hit 20,000 deaths this year, unfortunately. So, it's not a disease that's had its fangs pulled, like some say. They've been blunted, a couple have fallen off, but it's still there, and it's still a serious illness.
Steve, G, and Kit, very, very quickly.
Just one thing to add to that is that a lot of the time, 60 to 70% of the time, I think I'm right in saying that if COVID is on the death certificate, it generally tends to be the underlying cause, which is very, very different. 60%, yeah. So very different to influenza, where it's primarily bacterial pneumonia. That's not saying that either of them are not to be taken seriously, but it's a different game. It really is, and we should still be mindful.
And Kit, final words?
Yeah, just to draw back to the theme of this whole session, that's a great question, which I wish that modelling were ideally placed. I mean, SPIAM's been stood down, so we're not doing that modelling anymore. But unfortunately, the nature of COVID is there's so many uncertainties, in so many potential new variants, how this is going to impact the NHS, all these things that we just can't really get a good handle on. That actually modelling is blunted in the face of these sorts of difficult questions. So, yeah, it's one of those where we can make our best guesses, but we would have to caveat with huge amounts of uncertainty.
Okay, thank you so much, everyone. That was a fascinating session. And that is all the time that we have. So thanks firstly to Bob Hawkins for joining us today. And thank you to the members of the public who sent such brilliant questions in. And thanks to Christina, Kit and Duncan for putting together an absolutely amazing briefing. We will see you in 2 weeks. Till then, take care and keep safe.
Bye there.
Bye.
Cheers, everyone.
Bye, everyone.